Good morning, everyone. My name is Aamir Saeed. I'm currently working as a GI fellow at University of Tennessee, Memphis. We are grateful to GIE for providing us this opportunity for the author interview for our recently published paper in GIE on utility of repeat colonoscopy attempt after failed colonoscopy, a systematic review and pooled analysis. I'm also grateful to my mentors and all the co-authors for this paper, including Dr. Ali, Dr. Sultan, and Dr. Kamal, and Dr. Aziz. So, a little bit background about colonoscopy with adenoma reduction rate and cecal intubation rate. The colonoscopy stand out as a reliable tool offering comprehensive visualization of the colon coupled with potential for therapeutic intervention. The failure to attain complete colonoscopy puts the patient risk for subsequent proximal colon cancer following the procedure. Often in unsuccessful cecal intubation, the alternative approaches of barium enema or CT coronography are pursued instead of repeat endoscopic assessment, even though these alternatives do not provide direct visualization or the opportunity for the therapeutic intervention. So we aim to conduct a systematic review and meta-analysis to assess the outcomes of repeat colonoscopy after previous incomplete procedure. A comprehensive literature search was used, including major databases, PubMed, Embase, Web of Science, and Cochrane Library, and we included studies that reported the data on patients undergoing repeat endoscopy after previous failed colonoscopy attempt. Pooled rates for different outcomes were calculated, and meta regression was also carried out with statistically significant p-value less than zero point 0.5. We included total 26 studies with 1,647 patients, and 61% of the patients were female in our analysis. Overall cecal intubation rate on repeat attempt was 95.7% with standard colonoscopy. So we did a subgroup analysis of cecal intubation rate with based on different types of scopes. With the standard colonoscopy, cecal intubation rate was 96.2%, and with single balloon enteroscopy, it was 96.8%, and cecal intubation rate with double balloon enteroscopy was 93%. So we also performed different subgroup analysis based on the studies. So overall, cecal intubation rate on repeat attempts in the US and Canadian studies was 95.4% as compared to European studies where the cecal intubation rate was 93.7%. And also the cecal intubation rate in Hong Kong and Japanese studies was 99.2%. The secondary outcomes of our analysis include overall adenoma rate on the repeat attempt, which was 36%, and subgroup analysis based on the scope used showed overall adenoma detection rate with standard colonoscopy was 38.6%, and with single balloon enteroscopy it was 38.2%, and with double balloon enteroscopy it was 33.8%. Overall, neoplasia rate on repeat attempt was 2%, and with subgroup analysis based on different scopes used, the neoplasia rate with standard colonoscopy was 1.7%, and with single balloon enteroscopy was 1.9%, and with double balloon enteroscopy it was 3.6%. We also did a meta regression when controlled for variables including female gender and the age. The results did not reveal any significant covariables. So in our conclusion, repeat colonoscopy attempt in case of incomplete colonoscopy yielded a commendable cecal intubation rate of 95%. Importantly, this also enables potential therapeutic intervention of neoplasia and adenomas. Thank you, and we want to say thank you to GIE again for providing us this opportunity to record the interview for our recently published paper.